Almost 120 people are logged in with us over here, around 80 over here in the room, and another 120 are logged in and viewing the proceedings live. I would sincerely thank CIPLA and their entire team. It has been a great support which they have given for this meeting, right from arranging the travels, the nitty-gritties, and of course, to top it off, the web telecast. Thank you so much. Now I would invite Dr. Shahin. Okay. Okay. He's going to talk to us about a very complex thing, which is how do we assess pulmonary hypertension and pulmonary vascular disease in a single ventricle scenario. It's a complex talk, and it's a very difficult decision making, and I hope Dr. Shahin would throw a lot of light on it. For moderating this session, I would invite Dr. Krishna Kumar, Sir, Dr. Kothari, and Dr. Subramaniam.
Thank you. Thank you again, Prashant, for the generous introduction, and also for starting off my talk by saying exactly what I was going to say. This is a complicated problem and a complicated subject, and it's probably too complicated for me, so I can't presume to tell you how to do this. So actually what I'm going to do is talk to you a little bit about how we've evolved the way we assess single ventricles at our institution, which is not the same as saying this is how it should be done. It's just one way of doing it. And then we'll try and pick out a couple of things. And for various historical reasons, our institution has focused very heavily on non-invasive imaging, and in particular MRI. So that's the direction we took, and that's going to be the direction of the talk. And really, before even starting the talk, I have to acknowledge one of the leaders in our institution for this, well, two of the leaders for the non-invasive approach, who are Professor Musarangu, who develops a lot of the sequences and translates them into clinical practice, and Professor Taylor, who leads the unit. So I'm going to broaden it to how to assess single ventricular physiology, or how we assess single ventricular physiology beyond just pulmonary hypertension, because the various physiological problems are all intertwined, which is why sometimes it becomes more complicated. But what do we mean by single ventricular physiology? Or this, there are a number of stages. The initial palliation, superior cava pulmonary anastomosis or connection, and followed by completion of the Fontan circulation. And traditionally maybe less than 10 years ago, at our institution, to move from one phase to the other to assess patient suitability, we would perform a cardiac catheter at each stage. And about 10 years ago, things started to change, and we started to explore the potential of MRI, CT, echo to assist this decision making, and eventually actually to replace the catheter in many situations, not all. So what are we looking for when we're assessing the univentricular circuit and its physiology? We're assessing for vessel narrowing, vessel stenosis, collateral flow, actual cardiac output or flows through the vascular bed, ventricular function, and valve function impact. And put that all together, and that's what comprises a Fontan circulation. And I think it's probably artificial to try and tease out one aspect. They all interact with each other. So this is how we would do it, and nothing wrong with that. An angiogram. This is to illustrate one of the early cases at the Glenn stage, working towards Fontan completion. And we're quite content with the anatomy there. Both branch pulmonary arteries look good, and you can confirm that with an MRI. The left pulmonary artery looks good, except you can have 3D imaging, and in fact the left pulmonary artery is slender. So rather than a projection image, already you can see there might be some further information about stenosis by taking it to a three-dimensional modality. And you can exploit that to explore vessel stenosis, shunt stenosis, and this early study by Professor Musarangu looking at the sensitivity and specificity of diagnosing shunt stenosis and vessel stenosis, showing that MRI in this case with angiography was sensitive and specific enough. So a number of other centers have done similar. I think this work is from Boston, and randomized patients to MRI or catheter. And in a way, there was a non-inferiority test. So you can they say, okay, well, you can diagnose anatomy with cath or MRI, but let's make sure that if you make your decisions based on cardiac catheterization, based on MRI, your outcomes are not inferior to if you diagnose them with cardiac catheterization. So patients in pink who had the MRI assessment were no more likely to have a length of a long length of stay or worse oxygen saturations than patients who were assessed by cardiac catheterization. And similarly, in a longer follow-up, the outcomes were no worse in patients who had had MRI assessment compared to cardiac catheterization assessment. This is we looked comparing echo and MRI to look at the branch pulmonary arteries. So this is the scatter plots comparing the right, left pulmonary artery measured by echo and MRI, and they correlate. They correlate okay, but you can see it's a false negative and a false positive rate with echocardiography. This was comparing CT now with cardiac catheterization, and showing CT is as sensitive as cardiac catheterization for picking up vessel stenosis. So in fact, hopefully we'll show you in the next, I'll show you towards the end. In fact, we replaced the initial assessment prior to Glenn procedure with a combination of echo and CT. One of the initial pushbacks at that stage was, be it MRI or be it CT, the angiography is static. So yes, you can get 3D vascular anatomy, but it's static. You can't. When you do an angiogram in the cath lab, you can see the flow, you can see the wash in, wash out, etc. And this is a normal angiogram. It takes 10 or 20 seconds of breath holding in an MRI scanner. But people at the same time, and in fact people in our institution, were developing faster and faster sequences, and developing sequences which could acquire 3D angiography in real time. And with that, what they were able to do is to mimic an angiogram, so it's time-resolved angiogram. So you can see the contrast bolus moving around the vasculature. And in a sense, now you're mimicking a full angiogram, but in 3D. And these are 1.3 seconds per entire volume. That's the temporal resolution. And Jennifer Steeden is one of the MRI physicists who developed this sequence, tested its sensitivity and specificity for looking at dilatation, vessel dilatation, and vessel stenosis. And I think the results are comparing breath hold, so the standard method, to the new method, and they were all comparable with a good correlation. Okay, so vessel stenosis is obviously one of the things we look at on cardiac catheterization or vessel narrowing with angiography, but other things we notice are collateralization, and patients develop venous collaterals, which we think are driven by pressure gradients and cause cyanosis. But they're quite easily visualized on angiography, quite easily visualized on MRI or CT, as well as standard angiography. Arterial collaterals, on the other hand, are driven by cyanosis and cause volume loading of the ventricles, but they can be quite difficult to visualize, even on an aortogram, actually, unless you do selective angiography. But because you can measure flow in different vessels, you can start trying to untangle where the different regional vascular beds from which the flow is deriving. So this slide would just show how to measure systemic to pulmonary collateral flow. You can measure the pulmonary venous blood flow by measuring with MRI the blood flow in all the pulmonary veins. Subtract the blood flow in the branch pulmonary arteries. Any additional flow is aortopulmonary collateral flow. Or you can do it in reverse and measure the flow coming out of the aorta and then the flow returning from the caval veins, SVC and IVC, and any flow that's missing is aortopulmonary collateral flow. So people have looked at this, we've looked at it, and other groups, and shown the amount of aortopulmonary collateral flow prior to completion of your TCPC correlates with the duration of hospital stay. And then this is GOSH data looking at predicting excess length of stay based on collateral blood flow. So collateralization itself, quantitatively, can give you an idea of the post-operative course of the TCPC. So that's systemic to pulmonary collaterals. What about the venous collaterals, which we see on angiography and which we believe are driven by pressure gradient, but also make assessment of the pulmonary hemodynamics difficult because they offload the vascular bed, so you can have an artificially low pressure even when you have collaterals, even with elevated vascular resistance. So in this study, Marina Hughes simply graded visually, subjectively, the venous collaterals into 3 grades. So collateral grade, to look at whether it correlated with outcome, and correlated it with post-operative length of stay. So this was a retrospective study, so obviously it wasn't designed a priori to do this, but the collateral grade correlated reasonably well with post-operative length of stay, implying that, as we believe, these venous collaterals are a sign of adverse physiology in the circulation. You can try and take that one step further and try and estimate. This is not how to measure it, but this is a way of estimating the pulmonary vascular resistance, or total pulmonary vascular resistance, at the Glenn stage prior to completing the Fontan. So when the patients have their CT and their MRI, we measure the central venous pressure just through a neckline. And then, as I said, you can measure the pulmonary blood flow at the branch pulmonary arteries, and you can get a total pulmonary vascular resistance. Of course, the left atrial pressure is added on to that. So with that pulmonary vascular resistance, you can then try and predict what will be the central venous pressure once the circuit is completed. So you take the vascular resistance that you've just calculated and put through it the aortic flow, which is going to be taking, which is going to take the entire cardiac output, and estimate what will be the Fontan pressure. And so these data are being worked on by Michael Quayle, who's a postdoc in our center, looking at whether predicting CVP, postoperative CVP on the preoperative assessment predicts risk of early Fontan failure. So he looked at retrospectively at a whole bunch of patients, did this calculation, and then looked at the incidence of postoperative Fontan failure and the predicted CVP, albeit at a very high level, predicted adverse outcome, either at a threshold level of 33, which is an astronomical level, or just as a continuous variable. So for every increase of 1 millimeter of mercury, there was a 10% increased risk of early Fontan failure. Now moving on to how to measure the vascular resistance. Well, actually, Sachin published this in 2003, did this work with Andrew Reddington, using conventional cardiac catheterization. I didn't have a angiogram of a Fontan, so I've created one in the cath lab with a blue line. But just standard pulmonary artery pressure measurement using the Fick principle, but measuring oxygen consumption with a mass spec. Not taking into account collateral flow because it's not possible in this circuit. And looked at a number of features. This was an acute study, so looked at a number of features. First was, does the vascular bed, well, what is the range of resistances one can measure? And you can clearly see that the resistances hover around 2. I think the mean for the population was 1.8, but there are a few people with quite high resistances. And then, is there a response to nitric oxide? At this stage, they were looking at endothelial dysfunction, and he showed that there was a response to nitric oxide, and the response was more pronounced in patients who were considered to have had a pulsatile circuit. But also interesting for us is whether the pulmonary vascular resistance as measured correlated with markers of severity. There was no outcome data in this study, but patients with a higher resistance, unsurprisingly, had worse functional class. So that's how we used to measure flow using the Fick principle, but with measured oxygen consumption. Since, again, about 10 years ago, we started, and Professor Taylor brought this to our institution, MRI augmented cardiac catheterization, in which now all patients undergoing pulmonary vascular resistance studies for whatever indication, Fontan, heart failure, or pulmonary arterial hypertension, have catheters placed under fluoroscopic guidance in the branch pulmonary artery near a wedge position, so that where they can be manipulated into a wedge position. Then they transfer over into the MRI scanner. This is someone coming out, but it would go the other way, all under anesthetic. They have flow quantification in whichever vascular beds are of interest, so in this case the branch pulmonary arteries, simultaneous measurements of the pulmonary artery pressure, vascular ventricular function measurements, and then any nitric oxide studies which are required to work out the vascular resistance in each bed. So we looked back. These are the only data I have, and these are uncontrolled work looking at targeting pulmonary vascular resistance. So there have been randomized controlled trials which are a bit better, but it's off the topic. But we looked back at our patients who were treated for various indications with pulmonary vasodilators in a univentricular heart setting. At each stage, stage 1, Glenn stage and Fontan stage, and you can see the indications for treatment are there in the Fontan's protein-losing enteropathy, ascites, plastic bronchitis, so a range of indications. in an uncontrolled study with 1 or 2 drugs, at the time is primarily sildenafil or bosentan, and showed a statistically significant uncontrolled response of an increase in saturations in whichever category the patients were. A number of patients moved from one stage to the next stage, having been stuck previously. But at least in this small group, 2 drugs were no better than 1 drug. And then the subgroup of patients who had a repeat catheter study, the pulmonary artery pressure fell in response to therapy. So I don't think I could answer fully how to assess pulmonary vascular resistance in this group, except I suspect MRI is a pretty handy way of assessing, because you can measure pressure and flow in any vascular bed you're interested in. How to tie it all together is another matter. But before you leave the subject, I think you can't neglect ventricular function when you're thinking about Fontans, and I think a lot of the data that's very difficult to interpret in Fontans in terms of interventions, in terms of drug responses, because there's a combination of valve function, ventricular function, vessel function, and collateralization. So this is just to show that measuring ventricular function is also informative, unsurprisingly, in patient outcome. And this is why it's difficult to do any studies in these patients if you try and control for each of these factors. Ventricular function measured by echo or MR seems to predict prognosis in a cohort of patients with Fontan circulation. This is early post-Fontan. And I think on that I will leave it for questions. So at the moment, non-invasive imaging for the majority of patients at each stage of the Fontan circulation, with hybrid cardiac MRI studies to assess vascular resistance in a very small subgroup of patients where vascular resistance is felt to be the major problem. Okay, thank you.
Thank you, Dr. Shahin, for a very interesting talk on a very difficult subject. I have a couple of questions. How often do you find MRI is operator dependent? Whatever data they generate, if 2 people were to do that MRI data again, you think they concur? So how much of it is operator dependent? And how much of it is software dependent? Because we often hear we don't have this software, that software. So just since you do a lot of this, how much of it is a operator dependent issue?
Okay, so any modality has some operator dependence, but people have looked at it, and each new sequence that's been developed is tested for interclass correlations. And I don't know the data for this specific sequence for MRI, but except to say that when they were validated, the interclass correlations were better for most MRI modalities than other modalities, and so the reproducibility is good. I would personally, I consider it a gold standard. There is no such, otherwise there's no such thing as a gold standard, but the inter-observer variability and interclass correlation are the tightest for MRI measurements than any other modality I'm aware of.
Is it vendor dependent, that one vendor versus another vendor, different softwares are there? So they do generate different data, or they generate nearly same data?
So the sequences are different, and the methodologies are sometimes different. So where you segment, the volumes you get should be consistent for any particular methodology, and if you're using it in a serial fashion or a single institution fashion, it should be very reproducible. But for example, some people will segment out the trabecular, they'll only segment the compacted myocardium and leave the trabecular, but as long as you're consistent in your approach, it should be the same.
On the basic training, it should be generally good, right?
Absolutely. And also the final thing is, you don't have to use the vendor-supplied segmentation applications. There's open source software and applications available to download. In fact, that's what we use, the open source software.
Very roughly, would you just say after this investigations, how many patients you turn down, which you clinically would have thought, okay, they are okay for Fontan. Clinically, I take echo, etc. I think it looks okay. And then I do some of this. Do I really turn down them? Because my sense is that most of the time it doesn't really matter.
Well, no, I think you're right. Most of the time you know before that you're going to turn the patient down. In fact, that was one of the reasons for driving this, is that very few patients end up with a cardiac catheter now. So you can have your entire Fontan journey, and the most invasive thing you have is a JVP stick, just not even a full catheter. So it's gone from an invasive approach of cardiac catheter between two stages to awake CT scan between stage 1 and 2, and then sedated MRI between stage 2 and 3, and so less invasive for the very reason you're saying, is that actually for the vast majority of patients that's enough information to make your decision. You don't need anything more sophisticated than that.
Just a question on the method. Now, I saw your patient was intubated and ventilated. Wouldn't it be more physiological to do it on a spontaneous ventilation?
No, this is a good point. So again, as I said, we do very few pulmonary vascular resistance studies in Fontan patients. In fact, the Evelina Children's Hospital, which is also in London, have really driven the field with Fontan pulmonary vascular resistance studies. So we do very few catheters. One of the limitations, if you're going down the road of having a full hybrid cardiac catheter like I showed you, it's very difficult for a child to go in there with lines and inside the MRI tube, because it's very claustrophobic. It can be done, but it's very uncomfortable. So doing free breathing is difficult. What now our group has started going to the adult center, which is the Royal Free Hospital, and doing pulmonary vascular resistance studies by just a neck cannulation and then going into a normal MRI scanner, as if you're just putting a Swan Ganz in on the ITU. So they have it awake. But in children, while technically it's possible, I think most children would not tolerate it.
Stages right from the infancy, but very often we are faced with single ventricle patients who are presenting for the first time at 3 years or 4 years. Do you follow the same policy of doing an MR and not catheterize them, or would you rather catheterize them?
So the fallback, if in a way this is a screening process where the vast majority of patients, it doesn't pick up an abnormality, it doesn't pick up a problem, so ventricular function is fine, there's no indication that the pressure is elevated, you can, you know, you've fulfilled all of Fontan's 10 commandments, you're fine, you can continue. If there is a query raised, then those patients go for a catheter. So for the final determination, if there's a question mark, cardiac catheterization would still be the gold standard. But it's just maybe fewer than 5% end up going down that pathway.
Sometimes with multiple coils, there are artifacts. So have you encountered that kind of a thing? There's a lot of coils are there, and we do MRI.
Oh yes, this is 1.5 Tesla, and actually things are moving towards a low field MR rather than high field MR, because of you can get as much information with less artifact. The coils will affect flow measurements that are near the coils, but if you're the branch pulmonary, most of the coils are quite peripheral and things, so they don't affect flow measurements.
There are two types of coils. There's one which is MRI compatible and one which is non-MRI compatible. Non-MRI compatible, a single coil will destroy the entire field. And that existed, I think about 6 years ago. We were routinely using them. So we've got a bunch of patients who are not MRI suitable at all.
At all?
At all. Because the old generation coils were stainless steel that were not MRI compatible. Now you have a new generation coils that are a little more expensive, that are MR compatible, but they also do not allow you to get imaging in and around the place where the coil has been put.
So I mean, we just use the coils that are used in the cath lab. They haven't changed the choice of coils based on the MRI. but perhaps they're not the stainless
Yes,
steel
mi-
ones. They're,
The
but
UK migrated to the non-MRI, I mean MRI compatible coils long ago. We did not because we were sort of compelled to use them because of cost and other constraints. Same applies to pacemakers as well. It's more recent that we have MR compatible pacemakers. Most of the pacemakers were not MR compatible until maybe 4 or 5 years ago, and that would also not allow us to use any external wires. Somehow they don't seem to matter very much.
they're okay, yeah.
Thank you, Dr. Shahin. Now we go on to the next talk.